Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. Today in this lesson, I am going to touch briefly on the different aspects of most common hemoglobinopathies, that is sickle cell disease. Look at this picture. This infant is suffering from chronic anemia. You can see the pallor at the fingertips. We have taken the peripheral smear. The blood smear shows target cells and sickle cells. This is the patient with sickle cell anemia. It's a pathetic situation. Look into that. He's crying with pain. Well, coming to the sickle cell disease. It is one of the common hemoglobinopathies with qualitative abnormality in the hemoglobin. One of the hemoglobinopathies due to qualitative abnormality of hemoglobin. Genetically transmitted with autosomal recessive inheritance. That means the individual should get one defective gene from each parent and homozygous state manifests. It is the result of the point mutation in beta globin gene. Change in the base pair in the thymine replacing the adenine at 6th codon results in valine replacing the glutamine at 6th position in the beta globin molecule. That results in sickle hemoglobin, which undergoes polymerization in deoxygenated state. Okay. It could be homozygous, it could be heterozygous or hemizygous. Homozygous state is HBSS, heterozygous state is HBAS. Hemizygosity could be a combination of sickle hemoglobin with any of the other hemoglobin, that is HBS or HBF. In sickle cell disease, HBS is more than 50%, includes sickle cell anemia, HBSC, and HBS thalassemia. That means sickle cell disease includes sickle cell anemia in homozygous state, sickle cell with HBC disease, that means combination of the HBS and HBC, or it could be HBS with thalassemia. So this is the hemizygosity state. It means there is a combination of the sickle hemoglobin with other abnormal hemoglobins. That is, there is double mutations, okay, resulting in the combination of HBS and HBC in the same molecule. That is the hemizygosity state. HbS thalassemia is most common in our Indian patients. So, this is autosomal recessive disorder due to point mutation in the gene controlling the beta chain, thymine replacing the adenine S6 codon, which results in the valine, the amino acid replacing the thymine at sixth position in the amino acid sequence of the beta globin chain. Hemoglobin has got the two beta chains, two alpha chains in the adult hemoglobin. Okay. Sickle cell disease is due to the point mutation in the formation of beta globin chain. Then, once this mutation occurs and changes from the adult hemoglobin to the sickle hemoglobin, sickle hemoglobin undergoes polymerization in the presence of hypoxia or in the state of deoxygenated state. That results in all the pathological lesions. What happens? Hemoglobin S molecule in the RBC interacts to each other and forms rigid polymer in deoxygenous state. Polymerization occurs in post-capillary venules. Okay? This results in the distortion of the RBC shape to sickle shape, and cell becomes more rigid. Polymerization is reversible in lungs when HB is in oxygenated state. Okay. Sickle RBC causes mechanical obstruction to microcirculation, ischemic injury to tissues, and premature lysis of the RBC. A change in the globin chain results in the formation of the sickle hemoglobin. Once the sickle hemoglobin is there in the RBC shape is distorted due to the polymerization of the hemoglobin. Okay, and the distorted cell is more rigid. It cannot pass through the microcirculation. It causes obstruction to the microcirculation, thereby ischemic injury to the tissues. Okay, when it is re-exposed to oxygen in the lungs, the sickle cell becomes normal. But when this process is continuing, a stage comes when the sickling is irreversible. Okay, that leads to lysis of the RBC, resulting in hemolytic anemia. So, sickle cell disease is a state of chronic hemolytic anemia with hypertrophic obstructive vasculopathy associated with coagulopathy, resulting in the ischemic injury to the various organ systems. This is the definition of sickle cell anemia. Then, once the RBC is having a sickle hemoglobin, they have got more adherent properties. They are adherent to their RBC, vascular endothelium, to other cellular components in the circulating blood. They adhere to the vascular endothelium, they adhere to the RBC, they adhere to the other cellular components that are circulating in the blood. This results in the ischemic injury to the vascular endothelium, which triggers inflammatory response. Okay. Once there is inflammatory injury to the endothelium, okay, that results in the formation of microthrombi in the microcirculation. Okay. Okay, that is associated with vascular endothelial hyperplasia as a reactive phenomenon. As this phenomenon is going on, there is depletion of nitric oxide as a result of oxidative stress. Continued intravascular hemolysis, disturbed iron metabolism, episodes of aplastic crisis, all these phenomena leads a disease of chronic hemolysis with chronic hypertrophic obstructive vasculopathy with state of hypercoagulopathy resulting in ischemic injury to the organ systems. So this is the phenomena that happens in the sickle cell anemia. So that is the comprehensive definition of sickle cell disease. So it's a disease of chronic hemolysis with chronic hypertrophic obstructive vasculopathy with state of hypercoagulopathy resulting in ischemic injury to organ systems. This explains all the pathological changes secondary to the injury to the various organ systems. Look at this slide. This is the normal smear showing the red cells. Here the red cell shows distorted shape, that is sickle cells. There are target cells, okay, associated with anemia. This is how the sickle cells, they circulate in circulation, causing vasculopathy resulting in ischemic injury to the various organs. Because of this condition starts due to the genetic abnormality. The screening should be done in the newborn period in order to make the early diagnosis. Hemoglobin analysis is done by high-performance liquid chromatography. If the pattern shows FS pattern, that supports HBSS. During the process of newborn screening, you do the hemoglobin electrophoresis. FS pattern supports hemoglobin SS disease. If it is FSA, that is high levels of fetal hemoglobin, followed by equally high levels of sickle hemoglobin and small amount of adult hemoglobin. Okay, this is sickle thalassemia, wherein HbA2 is more than 3.5. FAS pattern supports sickle cell trait, that is fetal hemoglobin, adult hemoglobin, and sickle hemoglobin. AFS pattern is seen in post-transfusion neonates because there is adult hemoglobin is higher than the HbF and HbS. This is post-transfusion in the neonate with sickle cell disease. So this is how the newborn screening has to be done in order to understand the status of the sickle cell pattern in the newborn. Then coming to the clinical manifestations. They may present with fever or bacteremia. And children with sickle cell disease, they suffer from recurrent fevers. That's mainly because of the immune deficiency and due to early onset of functional asplenia, which will be seen as early as 6 months of age in a child with sickle cell anemia. So that presents with the fever associated with bacteremia. Child may suffer from aplastic crisis. Okay, when there is chronic hemolysis and bone marrow is subjected to stress, it fails to respond to the anemia, resulting in aplastic crisis. This is triggered by viral infections like parvovirus type B. This is the critical situation which has to be attended immediately in order to avoid the morbidity and mortality. Sequestration crisis. Splenic sequestration crisis is the next most common presentation with abdominal pain, enlarging spleen, and sudden drop in the hemoglobin level, and the patient may go into shock. Sickle cell pain, it is because of the tissue ischemia due to microvascular obstruction. Avascular necrosis, it is common with the hip joint. Priapism, painful erection of the penis, secondary to the occlusion of the corpus cavernous. Hepatic and gallbladder disorder occurs in chronic hemolytic process. In the same way, neurological, pulmonary, renal, and cognitive and psychological functions may be disturbed. Fever and bacteremia. It is a clinical emergency when the child presents with the fever secondary to bacteremia, caused by capsulated bacteria associated with high mortality. Immunocompromised as a result of as early as 6 months of age because of the functional asplenia. Treat with IV third generation cephalosporins. Await 24 hours blood culture report, which will be available before 20 hours. Observe the patient treated with ceftriaxone for life-threatening immune hemolysis. Okay. Children with sickle cell anemia, when treated with ceftriaxone, they will develop severe immune hemolysis, which is life-threatening. So, child when they treated with ceftriaxone should be observed for this particular devastating complication. Which will be identified by severe sudden drop in hemoglobin and rise in bilirubin levels. Suspect osteomyelitis, do bone scans if blood culture is positive for salmonella. Salmonella osteomyelitis, again a very common situation resulting in fever in infancy. Next, aplastic crisis. It is caused by parvovirus B19. Parvovirus B19 is has got the bone marrow suppression property. Okay, that results in the aplastic crisis. There is temporary suppression of red cell erythropoiesis. Profound anemia associated with fever, and there is reticulocytopenia. Okay? Well, parvovirus B19 infection is also associated with pain, sequestration crisis, and acute chest syndrome, glomerulonephritis, and stroke. Okay? It should be treated with blood transfusion. So when the patient presents with fever and sudden drop in the HB levels, and there is reticulocytopenia, you think it up as a aplastic crisis. But also look for sequestration crisis, acute chest syndrome, glomerulonephritis, and also watch for stroke. Then coming to the splenic sequestration. This is again common in the infancy between 6 months to 2 years. It is a life-threatening situation because there is sudden depletion of the blood volume secondary to the pooling of the blood in the spleen. Profound anemia with HB falling to less than 3 grams per cent. There is rapidly enlarging spleen with left abdominal pain. That's why mother has to be advised to look into the splenic size frequently by palpating his or her child's abdomen. So there is like reticulocytosis, okay, and thrombocytopenia, hypovolemia leading to shock. It is triggered by fever caused by bacterial or viral infections. Etiology is not known, but it may be triggered by fever caused by bacterial or viral infections. So treated with IV fluids and blood transfusion. So remember this point. Give the blood transfusion to maintain hemodynamic stability. Okay? Not to bring back the hemoglobin level to normal. So if you overtransfuse to get the hemoglobin level to normal, there could be danger of fluid overload because there is return of the blood from the spleen into the circulation, which is sequestrated during the crisis. Recurrence can occur mostly before 6 months of the last episode. Okay. Following this second episode, better to go for splenectomy. Next one, sickle cell pain. It presents in the infancy as dactylitis. Later on, it presents as acute vaso-occlusive pain. Dactylitis is common in infancy or under 2 years of age. It is also called hand-foot syndrome. It is first manifestation of pain. Okay. Occurs in 50% of the infants, and children under 2 years are affected commonly. Symmetrical or unilateral pain and swelling of the hand and foot. Okay. Treated by pain relievers. Next is the acute vaso-occlusive pain. Pain is so severe, unremitting pain with abrupt onset. Occurs mostly in chest, abdomen, and extremities. It is common in the extremities in the early age. In later part of the age, the pain occurs in the abdomen and chest. At least one pain episode in a year. Result of tissue ischemia due to obstruction to microcirculation. Triggered by physical stress, infection, dehydration, acidosis, hypoxia, exposure to cold, and prolonged swimming. So that is the reason why you have to caution the patients not to take bath in cool water. Treated by heating blankets, massage, oral pain medication. Sometimes it requires hospitalization for IV opioids, IV fluids to correct the dehydration. Next manifestation is avascular necrosis. Commonly affects the hip, again due to ischemic injury to the tissues due to obstruction to the microcirculation. Cause of acute or chronic pain in the hip region. Manifests as limp and limb shortening. Risk factors are HBSS with alpha thalassemia, frequent vaso-occlusive crisis, and elevated hematocrit, which results in hyperviscosity state resulting in vaso-occlusion. Treated with opioids for acute pain, followed by physical therapy. Then priapism. Mean age is around 15 years. Prolonged lasting more than 4 hours. Stuttering short episodes resolving spontaneously. Okay. Occurs between 3 months to 6 months. Occurs between 3 a.m. to 6 a.m. Sorry. That is most commonly in the early morning. Due to sluggish blood flow in corpora cavernosa. Recurrent episodes leads to impotence. Treated by hot showers and pain medication at home. Aspiration of blood from corpora cavernosa followed by adrenaline irrigation. Okay. Followed by that, take the urological service. This is the steps of management. Commonly occurs around 15 years of age. Between 3 a.m. to 6 a.m. is the risk period. It may be stuttering, short episodes which may resolve spontaneously. Sometimes it is prolonged, lasting more than 4 hours. In such situation, emergency management of the corpora cavernosum with saline irrigation and adrenaline infusion. Okay, then ultimately take the urological service. Sickle hepatopathy. It presents as fever, pain in the right hypochondrium, jaundice, mild rise in alkaline phosphatase, but resolves spontaneously. But sickle cell intrahepatic cholestasis resulting in jaundice, coagulopathy, hepatic failure requires liver transplantation. Okay, this is the chronic chronically involving the liver, its architecture is disturbed, warrants for liver transplantation. Neurological manifestations. Overt stroke by 18 years of age in 20% of the patients. Well, ischemic stroke resulting in a neurological deficit lasting for more than 24 hours with or without positive MRI. There could be silent stroke with MRI findings without neurological deficit that lasts more than 24 hours. She should be monitored by transcranial Doppler and with blood transfusions to maintain the hemoglobin level more than 10 grams per cent and HbS level less than 30%. Okay. Pulmonary manifestations. Second most common cause of hospitalization and associated mortality. Commonly involves left lower lobe, triggered by infections caused by salmonella, streptococcal pneumonia, mycoplasma, and chlamydia. Fat embolism from the bone marrow infarcts. Presence as acute chest syndrome associated with abnormal radiograph with any two of the following. Okay. Fever, respiratory distress, cough, hypoxia, and chest pain. So to define it as acute chest syndrome, there should be fever, respiratory distress, cough, hypoxia, and chest pain. Okay. Treated with oxygen, spirometry, antibiotics, SpO2 monitoring, blood transfusion, and pain medication. And children with sickle cell anemia getting admitted into pediatric emergency services. This is the most common cause. That is acute chest syndrome. Then go for blood transfusion if there is decreasing saturation, increasing distress, okay, and falling hemoglobin levels. With or without X-ray changes. Understood? Well, coming to renal manifestations. It could be late presentation. Nephropathy is a late presentation. It may take around 15 years or beyond. Presence as hematuria, proteinuria, hypertension, renal insufficiency, urinary concentration defect, and nocturnal enuresis. And children with sickle cell anemia, they suffer from cognitive disturbances. There could be retinopathy, delayed puberty, on leg ulcers. This is the spectrum of clinical manifestations a child with sickle cell anemia may present to you. Then coming to the diagnosis. Diagnosis is made in the presence of in the history of the clinical features and laboratory workup. What is the laboratory workup we are going to do? Go for complete blood count, sickle cell test, sickling test, HB electrophoresis, blood culture, serum bilirubin, X-ray chest, complete urinalysis, and other investigations based on presentation. Okay. Then in the presence of the clinical data, progressive anemia with onset late infancy, recurrent chest infections with wheezing, dactylitis occurring in infancy, splenic sequestration, pain, aplastic crisis, hemolytic crisis, history of recurrent blood transfusions. You collect the blood samples for laboratory profile. Blood counts. Do the hemoglobin in all the patients with the clinical data that you have collected. Hemoglobin to be maintained around 10 grams or above. That's the reason why you take hemoglobin in all the patients with sickle cell anemia. Falls down to less than 2 grams in splenic sequestration. This is the significance in splenic sequestration. In aplastic crisis, results in sudden fall. Low HP is a risk factor for stroke. Well, chronic anemia results in growth failure, complicated by bone marrow hyperplasia, contributes to tissue hypoxic damage and organ injury. Then coming to blood counts. RBC count usually elevated, PCV, MCV, MCHC normal range, WBC elevated, risk of SCI, platelet count elevated, signs of hypercoagulable state, and risk for stroke. Reticulocyte count elevated except in aplastic crisis. Then coming to lab profile. Continue lab profile. Peripheral smear shows normocytic normochromic anemia, presence of sickle cell, target cells, and oval jelly bodies, which indicates asplenia. Biochemical. Take this serum bilirubin, usually elevated, indicating chronic hemolysis. Liver enzymes, usually normal, elevated in sickle hepatopathy. Take the alkaline phosphatase, which is elevated in sickle intrahepatic cholestasis. Check for serum haptoglobin and hemopexin, which are low, indicating chronic hemolysis. Serum SCD levels are elevated. Iron profile is disturbed. Okay. Urine for microalbuminuria, microscopic hematuria, and hypostenuria. So this should be screened in order to know the sickle nephropathy. Iron profile. Study of iron profile in a sickle cell anemia is a big study. As such, iron profile, disturbed iron metabolism in sickle cell anemia is again a big topic which has to be covered in separate class. Then go with the therapeutic considerations. You have got the hydroxyurea, folic acid, penicillin prophylaxis, immunization against capsular bacteria, hemopoietic stem cell transplantation, okay, red blood cell transfusion could be episodic or regular, iron chelation ultimately is required in the children going on regular transfusions. These are the therapeutic plans in a child with sickle cell disease. Hydroxyurea is a wonderful molecule. It is an immunosuppressive drug having the properties of HbF gene inducing properties. It is a HbF gene inducer. It increases the HbF levels, improves hemoglobin levels, improves red cell hydration, reduces degree of hemolysis, okay, reduces cytoadhesiveness, elevates HbF levels, reduces O2 delivery, reduces O2 delivery, yes, because HbF level, HbF has got the more affinity for oxygen. So because the oxygen is retained within the cell, there is no deoxygenation of the cell, the deoxygenation of the hemoglobin, thereby going to sickling. Reduces leukocyte count, reduces platelet count, okay, increases EPO levels, improves nitric oxide level, thereby helping vasodilatation and reducing the vaso-occlusive crisis, decreases LDH levels, frequency of transfusions come down, and overall survival time is improved. So there are so many benefits of the drug hydroxyurea. That's why this is a wonderful molecule that has been given to the patients of sickle cell anemia. Start as early as possible, around 9 months of age. Start with 15 milligrams per kg per day, followed by stepping up the dose at as 20 milligrams per kg. Follow-up should be done after 2 weeks and for continuously for 3 months. Every 2 weeks for 3 months. Follow-up every 1 month for 3 months. Step up 25 milligrams per kg if response is inadequate to a maximum of 35 milligrams per kg per day. Once every 3 months, follow-up. What are the indicators of good response? Rising HbF level more than 20%. We have seen in so many patients. If baseline HbF is very low, that is less than 5%, response is good. In patients with HbF level very low, that is less than 5%, the response will be good. But in our patients, HP level usually we find more than 15%, baseline HbF level. Rising MCV more than 100 is a good response. Well, if there is leukocyte count is less than 2500, if the platelet count is falling, if the hemoglobin level is also falling less than 5 grams, stop hydroxyurea. But hydroxyurea has got no effect on nephropathy, TRV, and SCA. Has risk of developing male infertility. This has to be kept in mind when you are treating male patient with hydroxyurea for a long time. Other drugs that can be given are glutamine, which improves pain crisis, modest effect on ACS, no effect on rate of hemolysis. Well, crizanlizumab improves crisis, but no effect on hemolysis. But now there is a voxelotor drug that is approved by FDA. It is HB oxygen affinity modifier, reduces hemoglobin polymerization, reduces hemolysis, improves tissue oxygen delivery. So this drug is nowadays being used for the patients with sickle cell disease. The common steps of approach to sickle cell disease. Symptomatic, like pain relievers, supportive, give folic acid and vitamin supplementations, preventive, do the by immunization and antibiotic prophylaxis, abortive, in acute condition, treat the patient to abate the severe infections, curative, like gene therapy and stem cell transplantation. This is in general, the steps of approach to a child with sickle cell disease. Thank you very much for patient listening, and we smile at you. Thank you very much. Bye-bye.